We're going to move over into the next section, which is the acute disease section. And we have a number of speakers. Oh yeah, I'm on here too. I guess I'm here again. But we're going to have Dr. Ruchir Shah from Memorial Hospital talk on acute stroke, and then Dr. Matt Wiisanen talk about acute PE and acute MI. And this is where I want you all to start asking questions. It's important that you get the questions out that you want to know, and then I'll be talking about acute lower extremity ischemia. Dr. Shah?
All right. Hey, thank you so much. Hope you're all having a good time, and thank you, Dr. LeSar and team, for inviting me to give this lecture. I think we're going to go through this acute stroke treatment, and I think each of this topic requires its own lecture, but we're going to try to zoom through all this topic very quickly, and we can have a question at the end of this, after this session over. So no disclosure. Kind of objectives are like we're going to type of stroke, pathophysiology of stroke, risk factors, how do we treat, diagnose acute stroke, and then how recently we are using more and more AI technology to diagnose and treat acute stroke. I want to just touch base at the end of that talk as well. So why are we talking about the stroke today? Like it's as we know, it's a #1 cause of disability worldwide. It's a 5th leading cause of death in the US. On top of that, in the world, around 12.2 million people get stroke every year. And 1 in 3 seconds, someone gonna suffer a stroke in the world. So it's very important that how we can diagnose, treat, and prevent the stroke to improve this number. In the world, we kind of spend around $860 billion worldwide to treat and take care of the stroke. Also, it's no longer a kind of disease of the old population, right? Around 65% stroke happen in age less than 65 or less than 60. So we see more and more young people coming with a stroke. So how we diagnose those patients and put them back in the society, I think that's also important. What are the cause for the stroke? Like some of the leading cause of strokes are like same as we've been talking about for last 2 days, same risk factors as a vascular disease anywhere, high blood pressure, cholesterol, diabetes, obesity, lack of physical activity, and diet, smoking, alcohol, it's kind of the same thing. The good news for the stroke, 80% of the stroke can be prevented if you have kind of good primary care prevention, take care of the blood pressure, cholesterol, all this risk factor control. And I really encourage everybody that they just came out, American Heart Association came out with a primary stroke prevention guideline just last month. So see how we can take care of those people in the community before even the first stroke happens, and we can prevent the stroke. So what are the types of stroke? Like one is called ischemic and the hemorrhagic. Ischemic is due to the lack of blood flow. As you all know, hemorrhagic is the rupture of the blood vessels. There are several types of hemorrhagic stroke. For the purpose of this talk, we're going to focus mainly on ischemic stroke, but then the hemorrhagic strokes are like subarachnoid, subdural, intraparenchymal, or epidural. But the majority of the strokes are ischemic, which is around 85 to 87% of stroke due to clot in the blood vessels. I think as a community and anywhere, like it's very important to diagnose, determine the TIA, and treat them as acute or as emergency as a stroke, because somebody might having a what we call TIA, and we can do something to prevent actually happening the stroke in those patients. So it's called a transient ischemic attack. It's a warning stroke. So that they could have a clot somewhere from the blood vessels or from the heart that went into the brain and have transiently blockage of the blood flow, and they have a stroke-like symptoms like anybody would have with the stroke. But then in their case, the clot dissolves spontaneously, and they might not have any remaining symptoms, and they feel completely better. Many of the patients, they just don't do anything. They just stay home. Yeah, this happened last week. I did not think about anything. I stayed home. So I think it's important that we give the education. They treat as emergently as a stroke and go to the nearest stroke center or go to the primary care doctor for further evaluation. The types of stroke is a thrombosis, embolic. The thrombosis, if they could have a kind of atherosclerotic disease in the carotid arteries or in the brain vessels, which cause a clot. Embolism is that they threw a clot from the carotid artery or from the heart or from the dissection. So it's kind of embolic stroke. Hypoperfusion, if they have a fixed stenosis somewhere in the carotid arteries or in the middle cerebral artery. Again, it's important that everybody remember how to diagnose a stroke, be fast, balance, if they have acute onset of any balance issue, acute onset of dizziness, E for eye, that if they have any blurry vision, double vision, or loss of sudden vision, like painless vision loss, facial droop, then if they have arms or leg weakness on one side, and if they have a speech problem, difficulty understanding, difficulty talking, getting words out. And the T is for time. It's called 911. Every minute we kind of wait for that, you get more problem in the brain. What are like if you have a right hemisphere stroke and the left hemisphere stroke? What are the usual symptoms are when you have is the simple concept of the right hemisphere of the brain controls the left side. So if you have right brain stroke, you're gonna have a left-sided weakness. If you have a cortical stroke on the right side, the eyes deviates towards the stroke, so you're gonna have a right gaze preference and left side weakness. If you have a left side stroke, you're gonna have a speech problem in addition to the right side weakness and left gaze preference as well. If you have a subcortical stroke, like in areas called, like we call the basal ganglia or internal capsule or brainstem, then you don't have those cortical signs, but you have a pretty profound weakness on the arm and leg combined, kind of equal weakness on the one side. If it's a brainstem stroke, then that is very tricky, sometimes can be very tricky to diagnose the brainstem stroke. They might not have any weakness, might not have any other obvious symptoms like that you see with the cortical stroke. They just come with the acute onset of nausea, vomiting. They're not able to stand or not able to walk. They're just throwing up, or they become drowsy and acutely become kind of completely comatose within a minute. So that's all sign of basilar artery occlusion or blockage. So it's very important if somebody has a new onset, altered mental status, dizziness, nausea, vomiting, to think about this could be a posterior circulation stroke as well. And not all stroke just comes with the focal weakness on one side. So I think when somebody comes with a stroke at the hospital, this is purely we're going to talk about in an acute setting, that when they come in, first in the community, it's important to determine the stroke symptoms, identify, call 911 as soon as they come to the hospital or designated stroke center. Then this thing started, that you have a system of care in the hospital that they comes in at CHI when if ambulance bringing the patient, they will already call pre-alert us that there is a possible patient coming in with a stroke. So they alert the whole stroke team, and we would meet them in the ambulance bay. Or if they come through triage, they get the priority and they activate the stroke alert, and they don't room the patient. They go directly to the CT scan from the triage. So the whole stroke team responds. So what do they go through the series of imaging, like with the heart, it's the EKG is the key thing. For brain, is the CT scan is the kind of EKG that for every patient they goes to, they get the first CT scan to make sure whether they have a bleed in the brain, or sometimes if acute ischemic stroke would not show up on the CT scan immediately. It takes 24 to 48 hours to show up. But mainly the reason is to look for a bleed in the brain, or obviously if they have a tumor or something, if they come see the stroke symptoms, to rule that out. Then they go to the vessel imaging, that CT angiogram. Every stroke patients, they go to the CT angio to look for carotid, vertebral artery, basilar artery, and the MCA, middle cerebral artery, that they have a blockage. In this patient, you can see here in this right M1 that the right MCA, right middle cerebral artery, you see the cutoff sign. So this patient is having a right MCA stroke syndrome. In addition, we also, like many patients, because nowadays the stroke treatment has advanced, we want to select the patient that who can benefit from a thrombectomy, right? Like a patient comes in that they have a symptom last known well might be for 2 days or 1 day. We don't know how much brain damage has already happened and how much brain we can save. So this is like advanced imaging that called CT perfusion. So the red part you see in that is basically tells you that this is the brain area of the brain which is dead, okay? In short, that area is non-salvageable, okay? And the green area is getting a delayed blood flow. But it's still not the whole area is dead. So you kind of take the green area, subtract that from the red, and the green minus red, that's the area that you can see as a mismatch volume, that 46 cc, that's still at stake. If you do not remove the clot, then that 46 cc will also be dead in next few minutes or few hours. So that's why we know, okay, this patient is still a lot of brain tissue that we can save, so they go for thrombectomy, and that's how we make a decision for which patient in those borderline cases that this patient gonna benefit from thrombectomy. If the green and red like both match, then kind of there is not much brain to save there, so those patients not gonna benefit from thrombectomy. So at CHI, we also do this, like for thrombolytic treatment, you can only give thrombolytic up to 4.5 hours from the last known well. Now, many patients, they will go to bed at 11 p.m., right? And they say they woke up at 6 o'clock and they woke up with the symptoms. Now, we don't know whether this stroke happened at 5:45 a.m. or happened at 11:15 p.m. If it happened at 11:15, of course, they're out of window. So how do we determine that this stroke is actually 4.5 hours old? So at CHI, any patients who come with what we call the wake-up protocol, the study came out like 5 years ago that we do this acute MRI protocol. So they will get a CT scan, make sure they don't have bleed, and they check vessels, make sure that they don't have any blockage. Then they immediately go to MRI. They don't go back to the ER room. They go to straight to MRI, and we do this MRI. So as you can see, there's a 2 sequence, particularly in MRI, we call the DWI, this diffusion wave imaging, and the flare. And we compare if it shows up on diffusion but does not show up on flare, that means the stroke is still 4.5 hours or less. If it shows up on flare also, then it's more than 4.5 hours. So based on that, it's called DWI flare mismatch, and we can give TNK or thrombolytic treatment based on that. In fact, I just gave this one this morning, kind of based on this protocol. So we've been doing this protocol for like last 3 years, and still very few centers in the US does this protocol, but it's going more and more expanding. As we know, kind of time is brain. 1.9 million neurons die every minute you wait. Your brain kind of age 3.5 years every hour without treatment. So it's time is the essence when we kind of dealing with this brain stroke. What are the options as we talk about the IV thrombolytics? We give tenecteplase for acute stroke treatment. It's 0.25 milligram per kilogram, and the max dose is 25 milligrams. So we want to give it as many TNK safely to as many patients as fast as we can, right? And we are very proud that we give our average time for the whole year is like around 20-25 minutes we give, and the fastest we give like in 7-8 minutes from the door they come in. In 7 minutes, they would get that TNK. So you require a really good team to do all those things. But then the second layer is the thrombectomy or the clot retrieval that they will, as we show that they will go to the vessel imaging. If they meet the criteria for thrombectomy, they will immediately go from the CT scan directly to the cath lab and try to take that clot out. And the third is, in addition to all this, we always evaluate every single patient. At any moment, we have like 4 to 5 clinical trials going through at our hospital. So every patient, if they do not qualify for this acute treatment, we kind of filter them for any sort of clinical trial that they can participate, and we have that discussion with the family, patients, see if they kind of want to participate in those clinical trials. Tenecteplase is a third generation genetically modified version of TPA. It has a longer half-life. The most important thing, it's given as a single bolus. You don't need a kind of bolus and infusion. It's a very 5-second bolus, so that's why kind of we like, especially with the drip and ship, with the kind of hospitals at outside, if they want to give TPA or TNK and they want to transfer the TNK, is much easier that they just push it and transfer the patient. For second, this is thrombectomy. Either you do the aspiration or stent retriever. They go with the same as a cardiac cath, or what Dr. LeSar does, through the radial or femoral, and will go in the brain vessels and try to remove this clot out. This is, you can see, it's a right M1 occlusion image on the left side. You don't see any MCA vessels, and then this is on the right side. After the thrombectomy, you see all the vessels are open, and you see the clot at the bottom, the clot came out from the brain. So lastly, I just want to go through kind of how the AI has changed kind of the way we kind of practice, especially in the stroke. Before, kind of you have a stroke, you have large vessel occlusion. As a vascular neurologist, we kind of require to look at our own scan and look at the CTA, but still 80-90% of the stroke center, they do not have that kind of capability that neurologists can interpret their own images. So until the radiologists read that CTA, or there is an M1 occlusion, which can be 30 minutes after the CTA angio are done. Now with this technology, within 3 to 4 minutes on my phone, I'll get a notification. The AI will detect that there is an M1 occlusion or MCA occlusion on this patient, and within 3 to 4 minutes, the whole team will notify. Everybody gonna talk, everybody gonna chat on this platform that there is an M1 occlusion, what's the exam, what's the plan, and let's activate the IR team, right? So it has changed the game, especially for the referring hospital, that they can detect this within where they don't have neurologists at all, and they will have this tool, and within 3 to 4 minutes, their ER team will know there is an M1 occlusion, call the comprehensive stroke center and transfer that patient. Before that, it would take 1 hour. Now it's within 15 minutes, we would transfer those patients. If any patient has ICH, again, the same thing. Within 2 minutes, you get notification that there is a possible ICH on this patient, if there is a subdural. So we kind of, now it's a natural second nature, all this technology is part of our day-to-day workflow, that how we utilize them, and cannot imagine without them, like how we can work anymore. So it's kind of, it has become a part of our day-to-day life, that how we treat the stroke patients. I think beyond acute stroke, I just want to touch base that what we do kind of uniquely in the kind of terms of how we, beyond the kind of acute treatment, what do we do for the stroke diagnosis, right? Like stroke, especially the etiology of the stroke. If this is all acute setting, it's good, okay, we did the treatment, but there are 80% of the patients who come who are not gonna qualify for thrombolytic treatment, not gonna qualify for thrombectomy, and all those 100% of the patient needs a proper diagnosis and etiology of the stroke, that what caused the stroke, okay? Our job does not end that you treat and okay, they go home on aspirin, Plavix, or statin, but there are like a lot more to that whether they have underlying atrial fibrillation, they have underlying dissection, they have underlying any endocarditis, or they have any other vasculitis. So it goes a lot into the diagnosis of the stroke. So I'm not going to talk everything, but the one important thing, and kind of I miss working with Dr. Wiisanen. We used to work a lot about the PFO, that how we diagnose and how we treat the PFO. And Dr. Wiisanen is like a world-renowned structural cardiologist. So we used to work a lot together on that particular topic. So what tools do we use to diagnose? So in traditionally, usually you use a transthoracic echocardiogram, right? That it's a surface echocardiogram. It's easily available, but it's only around 60% sensitive. It's not a good sensitive. It's a position dependent, tech dependent, that hey, whether you're gonna And also the interpretation, whether it came after 2 cycles or 3 cycles or 5 cycles. So it's not a great sensitive tools, but easily available. The TEE kind of considered gold standard, but again, you cannot do the good Valsalva when you do the TEE, especially because they are sedated. And then there's transcranial Doppler, which is extremely sensitive for PFO, but the limitation is that it's a tech. You do not find many tech who can do the transcranial Doppler manually. So kind of the PFO, especially in the young population, is very important cause that if you miss that, that could be the only cause for the stroke. You kind of rule out every possible thing, and you could not figure out why this person would have a stroke. And the TTE, and sometime in occasion we have TEE would also be negative for PFO. And then how do we diagnose, or how we don't miss that? So traditional TCD is like difficult to learn, difficult to perform, and have variable quality. So at CHI, we've been doing this for the last 3 to 4 years. That was called robotic TCD, that you do not require any expertise or any tech training. You just put the robot, it isolates the MCA vessels by itself. The transcranial Doppler, it's isolate the vessels on both sides together, and you do the bubble study, same you do with the echocardiogram, but instead of looking into heart, you're looking directly in the brain, those bubbles, whether it's showing up on the brain. If it shows, then they have a connection, they have a right to left shunt. We don't know exactly whether it's a intracardiac and extracardiac, but then the second layer of more advanced cardiac imaging and the cardiac workup comes up, but at least you want to diagnose that to kind of go to that next level. So I think we did publish this study in like October last year. It was published, and we presented at multiple conferences that we compared the robotic TCD with the echocardiography to look for a right to left shunt. It was like kind of all over the U.S. Multiple hospitals participated, and it was compared the TCD with the TTE. So the bottom line, the result shows that a TCD, it shows 3 times the number of shunt compared to TTE, as a 63% versus 20%. Not just that, it kind of 3 times the number of intervenable shunt, that those patients went to the cardiologist and had a further workup and kind of refer for the closure for the PFO, which would have missed with this TTE alone. So it's important that kind of diagnose the stroke patients, especially the etiology. Not every stroke has the same etiology. They have, depending on their age, depending on underlying risk factor, you want to go into more detail. What could be the reason for the stroke? So the TCD in current guidelines is coming more and more at the center of this cryptogenic stroke, where you do not know the exact etiology. The TCD should be the center, kind of one of the important aspects to make sure that you are not missing the right to left shunt for those patients as well. I think these are all available completed clinical trial at CHI and ongoing clinical trial that we are doing right now. And then this is our neuroscience team at CHI Memorial. Thank you so much.
Thank you, everybody. I always enjoy hearing Dr. Shah give the updates. I always feel like if I'm looking for what the latest and greatest care in acute stroke care, he's always on top of it. And I do really miss working with you for a lot of reasons, but very nice talk. My name is Matt Wiisanen. Thank you all for having me here. I believe this is my 3rd go-round presenting at this conference, and so it's truly an honor to be here and to be able to present an update first on acute pulmonary embolism management, and then we're going to get into acute MI as well. So I do have some disclosures that are relevant for this discussion, in that I do a lot of consulting work for a company called Angiodynamics, and was one of the co-creators of the catheter that we now use from that company in the use of pulmonary embolism, but I'll make full disclosure of that when we're talking about it. And then I was previously involved in some of the earlier clinical trials with catheter-directed thrombolysis, and I tend to use the competition device that the Inari most often, and most recently have gotten involved in using some of the other cases as well in Penumbra. This is what we're talking about. This is what we're trying to pull out of people's lungs when they come into the hospital with acute pulmonary embolism. And the success of being able to do this now has grown exponentially over the last several years, both with the catheter technologies that have come about as well as techniques and diagnoses. And so what we have to look at is sort of the spectrum of venous thromboembolic disease and its management. Now, I won't necessarily get into DVT today, except to say that this is where all PEs come from. So all pulmonary emboli are coming from some sort of a clot in the deep venous system typically, and many times when you find somebody who has a PE, they oftentimes will have a DVT that is also either not yet diagnosed or about to be diagnosed. It is the third leading cause of death, though, for pulmonary embolism, and it has a very high mortality rate with the 30-day event rate of up to 15%. And what's fascinating and what we've been learning over the years with just standard anticoagulation therapy is that up to 50% of patients will still have some sort of large vessel occlusion after their event is completed, after they've finished oral anticoagulation, and this results in a lot of morbidity down the road. So again, a fairly deadly disease, a number of hospitalizations per year for venothromboembolic disease, and death rates that are just way too high to accept. Now, 1 in 5 of these patients is readmitted within 30 days, and it is an economic disaster for this country in particular, $10 billion annually. So the case rate is relatively high, 1 to 2 pulmonary embolism cases per 1,000 people, and if you get into older populations, that rate goes up. So PE typically, as I said, originates from a lower extremity DVT, and 79% of these patients will typically have both PE and DVT that can be diagnosed simultaneously. Of those diagnosed and of those who get treatment started early, there still is a 5% overall mortality in these patients. And there's a 70% mortality if they also happen to experience a cardiopulmonary arrest. 30% mortality if they present in shock and need pressor support. And then a 6 to 15%, give or take, range of mortality if they aren't in shock, but they have evidence of strain on their CT scan. So you can see that what's interesting is that the annual event rate continues to increase. And this is for a number of different reasons, in part that we're doing a better job of detecting these, and we're doing a better job of being able to identify patients who have this, whereas we didn't do as good of a job previously. I always joke that if a patient asked for directions to an emergency department these days, they'd probably end up with a CTP protocol. Now, in 2008, the Surgeon General had a call to arms and said, listen, there is a real problem of venothromboembolic disease in the United States, and we really need a call to action. So he urged coordinating these multifaceted plans that would result in a way to reduce the burden of morbidity and mortality of VTE. What we're trying to ultimately prevent is this. There is a downward spiral that occurs when these patients get into trouble, and if there's a way that we can reduce this spiral, if we can intervene early enough to stop this RV dilation, to decrease the risk of RV failure, right ventricular failure leading to left ventricular failure, ultimately leading to cardiogenic shock and death, then we're doing a service to these patients. Now, for years, the traditional therapy has been, let's anticoagulate these patients, and that makes total sense and is still very appropriate. And so we typically will see these patients in the emergency department, and we'll start with a heparin-based strategy, whether that's unfractionated heparin, low molecular weight heparin, or whatever the case may be. Now, up until several years ago, the most standard anticoagulant therapy that was available for oral anticoagulation was warfarin. And so typically patients would be placed on warfarin, and then they would be treated for a period of time. Nowadays, we do have more convenient therapies with DOACs, and there are some very simplified strategies for getting patients initiated on this and getting them moving through an emergency department and into a primary care setting much, much quicker. Now, thrombolytics is something that we're going to spend a little bit of time on in terms of its overall role in the treatment of these patients, and there is still a role, but it's relatively limited. Now, what you can see is that over time, and we see this both in the brain as well as the heart and now in the lungs, that as time progresses, these clots become less fibrin-rich and more full of collagen, making them easier to treat earlier on and harder to treat a little bit later because they become a little bit more solidified. And so what you can see in these pictures here is that an acute clot may show up as being relatively, for lack of a better way of saying it, mushy and friable. And once it gets into the later stages, it's a little bit more rubbery and harder to treat, both with anticoagulation and especially with thrombolytic therapies. So if we look at the progression of disease and the management thereof, in myocardial infarction, we've been doing this for years, where we first started treating patients with a heart attack, just throw them on some anticoagulation and hope for the best. And then we started doing anticoagulation and thrombolysis, and we saw that there were huge improvements. And then guess what? Balloon angioplasty came around, stents came around, and we've had progression since then. Dr. Shah just went through sort of the progression of care in the stroke patients and how that's progressed as well. But now what we're seeing is that same evolution, that same evolutionary pattern is happening within the venothromboembolic space, specifically within PE, but also within DVT as well. So we have found that over the years, centers of excellence or programs that are designed to treat patients with these acute and significant problems have developed a team-based strategy where there's early identification of the patients. There is a coordinated approach to figuring out who needs therapy and who doesn't, and then proceeding on to an intervention or not based on a team-based discussion. So in centers of excellence, you can see that this takes a whole coordinated group of people to come together and discuss how to take care of these patients. And in using technology similar to what Dr. Shah did with administrating the AI-based apps, we are doing similar things at Park Ridge, where we have AI technology that's useful in helping me to identify on my phone a patient with a pulmonary embolism, to the point where now I'll get a notification. I'll see it on my phone, and I can call up that emergency room doc, and I can say, hey, you've got a patient with a pulmonary embolism right there, and they will literally tell me, gee, that patient is honestly wheeling back from the CT scanner into their room. They haven't even gotten back into their room yet. So it's fascinating the speed with which we're being able to detect these. We've seen over the years, much like in the realm of stroke, that we've improved mortality in the realm of MI. So in STEMI and non-STEMI, with our various interventions over the years, we've seen that we've been able to improve overall mortality. Not yet so in pulmonary embolism. We really haven't touched the mortality mark in pulmonary embolism as of yet. And so we still have a relatively high morbidity and mortality in this patient population, and it is ripe for intervention. And I feel as though we're at a time right now in our lives where we will actually be able to see change actually happening. So again, we talked about this, that if you look at patients who are treated just with anticoagulation alone, 30-day mortality is anywhere from 6 to 15% in an intermediate risk population, and I'll explain what that looks like. Massive, patients who are in cardiogenic shock or have just come in with cardiopulmonary arrest, that's upwards of 25 to, as I mentioned even earlier, 80%. Now, if you give thrombolytics has made major advances in improving the overall mortality of patients, but it comes at a cost of bleeding, and bleeding can occur in anywhere from 9 to 22% of these patients, and so has really fallen out of a lot of favor because, as we all know, we're treating older and sicker patients, and many of these patients are going to have some relative contraindications to anticoagulation or, thrombolysis. Now, cardiogenic shock is present in upwards of about 40% of patients who may actually be normotensive, who don't necessarily need pressors, but if you look, they have a large clot burden, they have elevated lactate, and their overall, if you measure their indices on a right heart catheterization, their cardiac output is low, and they are doing poor perfusion of their organs. And so they are at very high risk of needing intervention. And what we also know is that if we don't intervene, a lot of the mortality can occur after a patient leaves the hospital. So after the index hospitalization, mortality can occur at a substantial pace outside of the hospital. So what we need to do is we need to identify patients early. We need to treat them and triage them through a clinical assessment. We need to do the appropriate imaging tests, which we won't get into necessarily today, but CT scan, of course, being the gold standard, and then preparing for referral based on knowing what our treatment patterns need to be, starting up front with some anticoagulation, and then knowing that we're referring to a center with an interventional strategy available to a patient. And so we can risk stratify patients simply based on their hemodynamics up front. We can then look at things on the CT scan like their RV to LV ratio, whether or not there's a large central clot burden, whether or not we have a whether or not we have a concomitant DVT, and then biomarkers, troponin, BNP. Those things are all very important in the risk stratification of patients. So we risk stratify on a system like this, where we have a minor or low risk patient, a submassive or moderate risk patient, or a massive and high risk. And simply saying is a submassive or a moderate risk patient will be those who have evidence of RV dilation but are not in shock, and then the massive or the high risk patients are those who are now in shock. So we can measure the RV to LV ratios largely based on CT imaging, and anything that is greater than a 1 ratio, an RV to LV ratio of 1 or higher, generally speaking, is considered abnormal. Your RV should be smaller than your LV. And so if it is not, then you have a problem. So again, we've talked a little bit about what the evolution of therapy has been, whether it's been anticoagulation, thrombolysis, but then there are other things: surgical pulmonary embolectomy, half-dose lytics, catheter fragmentation, catheter-directed lytics, and then pulmonary embolism response using mechanical directed thrombectomies. So not to get into systemic thrombolysis, but at the end of the day, we talked about this. The meta-analyses have shown really equipoise with utilization of this tool because of its risk of bleeding. Surgical treatment. This is a problem in a lot of surgical series with a lot of high-risk patients, where patients are sent off to surgery and they may look and do just fantastic, but guess what? They're very highly selected patients. So open surgical embolectomy is only something that's relegated to very specialized and high-risk situations in very specialized centers. Those centers don't routinely exist, and so getting those patients to those centers can be somewhat challenging. And you can see mortality still remains relatively high, and that if you go to a single center study where you have a mortality of 3.6%, well, that's fantastic. But again, very highly selected patient population. So prior to 2011, a lot of the percutaneous approaches that we had were catheter-directed with some really rudimentary tools, angiojet and trellis and such. And then after 2011, there's been an explosion of devices. Whether it's been large bore mechanical thrombectomy or catheter-directed thrombolysis, there has been an explosion in the market. So again, in pre-2011 terms, people might go in and try to break apart a clot using a pigtail catheter, spinning it around. The series of studies that were done were relatively small and relatively unhelpful in terms of directing further guidance for care to these patients. So the big study, the big to-do came in about 2012 when we had the publication of the Ultima trial. The Ultima trial was a publication of a randomization of patients to a catheter-directed therapy using an ECOS catheter system, where there was ultrasound-mediated thrombolysis, so it was TPA being infused into clots using ultrasound guidance, and these patients tended to do very, very well as compared to standard heparinization alone. And so we saw that there was a significant recovery in the RV size. RV size came down to more normal ratios, that PA pressures, which were measured, tended to improve, and the scores on echo for right ventricular function also tended to improve. In a single arm non-randomized trial looking at these patients, which I was a part of this particular trial, again, we saw the same thing, that when you compared to baseline or you compared to historical controls, patients who received this therapy tended to do much better in terms of their in-hospital mortality, their 30-day readmission rates, and their lengths of stay in the hospital in general seemed to improve. And then there was a trial that occurred in about 2015 called the Optimize trial, simply showing that we could do these therapies for shorter durations and patients still did relatively well, seeing that they had low event rates for bleeding complications and they still had significant improvement in their RV to LV ratios. So fast forward now to large bore catheters, and the first of this I really have to give credit to was Inari. So Inari really kind of came to the market and said, you know, we've got this large bore catheter, and let's see if we can treat all this in a single session. And lo and behold, these are typical results. These are things that we have gotten in our experience with using this kind of device. And so in the registry called the FLAIR, which was a single arm registry or a single arm study, you could see that within 48 hours you had substantial improvement in your strain on your right ventricle, that your right ventricle improved in size and your hemodynamics improved, that patients did well in this study, that there was very few complications, very few deaths, that an average length of stay for an ICU was only 1.5 days, and that there were many patients, almost half, who never even needed to come to the ICU to begin with. There were subsequent studies that were done, subsequent single-arm registry single-arm studies that were done, and again, showing very similar event rates. And you can see here, this is a patient who's got a very large clot burden here within their right pulmonary artery, and this is the material that's withdrawn afterwards. So when we look at a lytic-free thrombectomy environment, we see that by and large these are safe. The all-cause mortality in a lot of these studies is in the 1% or less range. The 30-day all-cause readmission rates are relatively low, and large clot removal with significant improvement in hemodynamics is what we are all trying to achieve. Now, the trial that I have a little bit of bias towards is the Apex AV trial, which is the trial utilizing the catheter that I helped to create. 122 patients, single-arm, prospective trial, procedural time roughly of about 37 minutes, which is significantly improved from the Inari studies, but again, a significant improvement in RV to LV ratios with a significant reduction in the amount of clot burden that remained pre and post, and only 5 major bleeding events with only with very little, with no deaths in the study. Now, the Extract PE trial was Penumbra's trial, and again, same thing. We see significant improvement in RV to LV ratios. We see 37-minute procedure times. We see patients doing well clinically with very low adverse rates. So this technology works, and we're moving quickly in this space with large bore thrombectomy to the point where now we have a number of other trials coming on down the pike, such as Peerless, which was a randomized controlled trial to catheter-directed lysis versus large bore mechanical thrombectomy, 550 patients in a 1-to-1 design. The statistics was a little odd, and ultimately showed that there was largely some benefit in their primary endpoint, which include mortality, intracranial hemorrhage, major bleeding, clinical deterioration, and post-procedure admission to the ICU. These patients tended to do better, largely driven by lack of needing to go to the ICU. Upcoming trials, we have the HI-PEITHO, the Peerless 2, and the PE Storm studies, which are all industry-sponsored studies, but the PE Track is an NIH-sponsored study, and it's going to look at catheter-directed lysis versus anticoagulation alone, and look at long-term outcomes. Look at things like 6-meter walk tests, look at VO2 max, look at quality of life scores, because, again, this is what's going to be important to us in getting patients through. This is a very busy schematic that we have at Centennial at Park Ridge, just kind of saying how we risk stratify patients and move them through, but ultimately it's coming together, having technologies, and knowing who to use these for. That makes a big difference for our patients. So in conclusion, the evolution of the treatment of pulmonary embolism has changed dramatically over the last decade. We have a number of studies that have come out, but we have a number more coming too. And the data right now is still in its relative infancy as compared to where we are with stroke, as where we are compared to MI. But it's moving in the the direction that I think we're going to see appreciable changes over the next several years, and hold on to your seats because it's going to move quickly. So we have many trials to come, and regardless of the technology, nothing can supplant the importance of people, clinicians, getting together to discuss in real time what the pros and cons of each strategy is to figure out what's best for our patients. So with that, I thank you, and we're going to quickly move on to our next topic, which is acute MI, and I'm going to see if the slides load. All right, so brief update. We've all seen heart attack, and we've all seen it over the years, and it's not too dissimilar than PE. We've got clots in the heart that we need to take care of. So it's just with smaller catheters this time. I don't have anything necessarily to disclose with this, as I am an avid user of all technologies within the space. So what we're going to do is go through the definitions of MI, discuss some of the trends that have occurred over the last several years, identify pathways for treatments for patients with acute myocardial infarction, and then go through some of these treatment pathways and discuss some of the pharmacologies. So again, this is a slide I'm sure many of you have seen. This is from the 2014 guidelines. And again, what we're really talking about is this lipid core developing underneath the artery or within the artery, and eventually having some rupture of that lipid core out to expose the lipid to the blood flow and potentially causing some sort of a thrombotic event. Now, there are lots of definitions, and we've all heard type 1 MI, type 2 MI, type 17 MI. There are all these different things. But again, what's most important is the clinical context. And we talk about this all the time in our institution about how clinical context is so important. Is somebody coming in complaining of symptoms that are consistent with having a heart attack? Is somebody then having, is the physiology correlating with what the patient is complaining of? Do they have EKG changes? Do they have diagnostic criteria based on blood testing and the like that are helpful in making this diagnosis, which is ultimately what we're trying to go for? Busy slide, but you can see there have been a number of things that can contribute to the presentation of somebody maybe having an acute coronary syndrome, whether it's coronary spasm or embolism or microvascular dysfunction, or heck, moving on to this category over here, looking at hypertension, hypoxia, anemia, what's causing stress or strain on the heart. What we're going to focus on here, though, largely is going to be the atheroma and the plaque rupture ischemia, what we've previously called type 1 MI. Now, what we're talking about in particular is a clinical syndrome that results from the occlusion of a coronary artery and the death of the myocytes in that territory. So you can see in this cartoon here, you have an occlusion of an artery and you have lack of perfusion to that part of the heart, and some of the pictures that Dr. Shah was showing similar to that of the brain. Very high prevalence, 13 million people every year having a heart attack, 1 in 6 ACS admissions in the United States alone. 1.3 million of those are the non-ST elevation MIs. About a third, or about 300,000 of those are actually ST elevation MI, and a person has an MI every 25 seconds in this country. There are 340,000 cases of sudden cardiac death annually. Women at age 40 have a 32% lifetime risk of developing coronary heart disease. A man at age 40 has a 49% lifetime risk of developing the same thing. So it's a very prevalent problem. But the good news, much like that in stroke, is that we actually have seen an improvement in mortality because of the administration of new technologies, whether it's cohorting patients into a coronary care unit, whether it's heparinization or some form of anticoagulation, or whether it's been thrombolysis, and now eventually moving on to stents and other medical therapies. So again, I showed this slide previously, but you can say that actually, unlike PE, we actually have made difference in mortality within the acute MI space. And so this has been drastically improved over the last several decades, and it has been fun to be able to watch that now. Just because somebody's had the big one, it doesn't mean that they go home to the morgue. So we have a lot of exciting things that are happening in this, but when we talk about identifying patients with MI, it really starts with patient education. Patient education is very important, and the American Heart Association has done a lot to really try to help patients identify what are those symptoms that you need to be looking out for to see if you are having a heart attack. So that way you then know, hey, maybe I need to go seek medical attention. You can see here that we've even progressed to the point where some institutions like the Marshfield Clinic have come up with some specific guidance for both men and women, identifying that, hey, you know what? Women are going to present sometimes a little bit differently than guys, and we can't ignore that, or we can't be put blinders onto that. We have to know what these signs and symptoms are so we can get people to attention. 98% of the U.S. is covered by 911 services, but only 60% of STEMIs, remember acute occlusion of a coronary artery, only 60% show up by ambulance. So how can I educate that patient who's having some symptoms, they think maybe they've got heartburn, to not come in by car, but maybe to call 911 and come in that way? Because what we see is that 1 in 300 patients will suffer a cardiac arrest en route to the emergency room. And I've personally witnessed this myself. So this is very, very important for us to be able to identify these patients, give the proper education, and make sure that they're identifying a 911 service provider to come pick them up. Because in the ambulance now, ambulances are equipped to do EKGs. We can make a diagnosis of, not a bad EKG, to, oh crap, right? And then the ER or the ambulance can actually physically call and activate a cath lab, and can even just zoom through the ER, not even stopping. Where this is important is out in Greater Tennessee. Gee, if I've got a patient at some location where there isn't a cath lab and they're having chest pain, if the EMS is able to do an ECG in the field, then they can actually triage that patient to a PCI-capable facility rather than bringing them to a hospital that doesn't have that service available. Once a patient, though, arrives to emergency department, they have to get the ECG within 10 minutes. Again, early identification is the key, and we must move forward to get these patients identified early. So you can see, just like Dr. Shah showed earlier, time is of the essence. We know that the longer we wait to open up an occluded coronary artery, the more myocardium will die and the worse these patients will do. So we have a metric that we like to use in the cath lab called our door-to-balloon time. The sooner we get somebody to treatment, the quicker, the better off they'll do, and their odds of improved survival go up dramatically. So when it comes to an acute occlusion of a coronary artery or a STEMI, we have to transfer immediately to a PCI-capable facility. So at an outside hospital, we need that patient into a cath lab within 120 minutes. If there is going to be a delay in transfer, which happens all the time here, weather, traffic, good Lord, traffic is terrible. Then we have to think about alternatives, and should we be giving fibrinolytic therapy to those patients, ideally within the first 30 minutes of arrival. They should be getting aspirin, they should be getting some sort of a heparinoid, whether it's unfractionated or low molecular weight heparin, or for those who've needed it, maybe bivalrudin. And then assess for signs and symptoms. My public service announcement, for those of you who may be treating these patients, please leave the right wrist alone. Because we know from our data that going with a radial approach for treating the patients in STEMI actually has a mortality benefit. In non-STEMI, we're given a luxury of time. We don't necessarily have to rush as quickly, but we have to prepare for transfer to a PCI-capable facility, doing serial EKGs if a patient's symptoms get worse, serial troponins, and then we want to achieve a chest pain-free status if possible in these patients, similar therapies. We have statins, which the only statins in myocardial infarction to use are either rosuvastatin or atorvastatin, either at 20 or 40 milligrams for Rosuva, 40 or 80 for atorvastatin. End of story. No simvastatins, no pravastatins, nothing else. These are the only two that are indicated by the guidelines. P2Y12 therapy, we take care of that in the cath lab. But efient-or ticagrelor or Brilinta, clopidogrel or Plavix, and then cangrelor is our IV P2Y12 therapy. There's some question as to the utility of beta blockers. We're not going to get into that today, but the important management here is getting patients chest pain free as quickly as possible. Cautionary meds that we talk about now, we don't use 2B3 inhibitors nearly as often as we used to. There's some question now about upfront loading with P2Y12 therapy. We specifically know that there's a harm in upfront loading in patients with Effient. Nitroglycerin has never been shown to improve the mortality or morbidity of a patient, but it can get them chest pain free. Be careful in inferior MIs and be careful with patients whose blood pressures are questionable. Morphine actually can activate platelets, so we actually try to avoid morphine, and beta blockers can push somebody who's on the fence into cardiogenic shock. So you can see here, this is a STEMI. You can see an acute occlusion of an RCA. You can see that it's opened, and you can see that with the placement of a stent, that this vessel has now opened, and this patient went from that inferior MI to doing well. We have a number of therapies to manage cardiogenic shock that we won't get into today, but identifying these patients up front for balloon pump therapy, Impella therapy, or at the end of the day, ECMO is going to be important as well, because many of these patients can progress on to some form of cardiogenic shock that may need advanced therapy. Long-term management of these patients, lifestyle modification is the big thing. So we have enjoyed a good partnership with Vascular Institute folks, and it's like we're singing out of the same hymnal. Lifestyle modification, exercise 150 minutes a week, smoking cessation, lipid management, goal LDL cholesterol of less than 55, shown to enable plaque regression. Diabetes management, blood pressure management, diet, Mediterranean, or I'm going to advocate for the whole food plant-based diet. And then cardiac rehab, which has been shown to have a survival benefit as well. Long-term dual antiplatelet therapy is recommended after an MI for 12 months in all patients regardless. Now, there are patients who can get 6 months of dual antiplatelet therapy if they got a stent but did not have an MI. And there's some data that'll allow for a shorter duration if it was an elective patient. So in summary, there are a number of ways to define MI. There are a number of ways we can talk about it, but the clinical picture is what's most important. Continued improvements have led to improvements in survival, and early detection is really paramount now to getting those patients more quickly treated and improve survival just that much faster. A PCI-capable facility is absolutely paramount to the care of these patients, and secondary prevention cannot be stated enough. And with that, I thank you.
All right, we're going to jump into acute limb ischemia. I'm going to be very brief and focus on what the most important part of this is for my clinical colleagues here. Acute ischemia needs to be in the operating room. That's where it needs to be, and there's a timing process that we have to go through. But there's a couple important things that we have to learn. When I was a young house officer, surgical officer, if a young child came into the ER with periumbilical pain that moved to the right lower quadrant, that was acute appendicitis. My job was to triage that patient to the operating room and get them there immediately so that we can prevent a ruptured appendix, and that's a much higher mortality problem. And so it's physical exam and history, which is critical. When it comes to critical limb ischemia, history and physical, here's the question: which foot is ischemic? This patient presented with pain in the right foot, worse at night with rubor. There's a hint there. Left had sudden onset of pain in the good leg. Which one is ischemic? Anybody? Hello? Does lunch get you? Which one is it? Right? Left? Anybody say left? Anybody say both? Both are ischemic. One's acute, right? Right has chronic ischemia. She has rubor to the foot. She has redness to that foot. Let's go back and look at that one time. And it's beautiful toenails, by the way. And but she presented with really acute ischemia to that left foot. And so clinical assessment is important to determine what to do next for these patients. First thing, if that happens to a patient, check their pulses. Feel their pulse. Got to touch them. That's how this works. Neuromotor exam. I want to see that her feet wiggle, her toes wiggle. The 56-year-old female, 24-hour sudden pain to the left leg. You can see that her toes on the right move, her toes on the left, they don't move. They can't move. She has ischemia, acute ischemia. And so that's a person that I need to see right away. As far as the neurosensory, you touch, you feel. Do you feel me touch here on the inside? Where does she not feel? She doesn't feel from there down. And so she has acute ischemia that needs to be in an operating room. And so we classify these patients as class 1, limb is reversible, viable without therapeutic intervention. That last patient was not that person. Class 2 is limb is threatened and requires revascularization for salvage. That is more than likely the person we just saw. Class 3 is irreversibly ischemic, and salvage is not possible. This is a patient that infarcted his foot, took about a month to get in. There's no way we can save this. Doctor, save my foot. Can't save your foot. Foot's dead. So that foot had to come off. Now this patient had gangrene of her great toe for about a month. Dark spot, putting betadine on it, not getting better. She infarcted her forefoot at that point. We could revascularize that patient 3 different times where we tried to open up the vessels, got the vessels open. It's all the small vessels that were gone and blocked. She lost her foot. So she was irreversibly ischemic. Now, class 1 is elective therapy. We have some time to fix things. That's a phone call to us. It's a person coming in off the street. We can decide when to fix them. Class 2, I want a text or a phone call. Got somebody that I'm really worried about. I prefer a text or a phone call. If you want to send them to the ER, that's fine. They'll call me. But if you let me know ahead of time, I can help direct some of that. Class 2B is urgent therapy. They're profoundly ischemic. Class 3, ultimately, it'll be a major amputation in the hospital. And so I'm going to stop with the acute assessment so that we can get back on time. I'd like to get Dr. Shah and Dr. Wiisanen back on stage for a second and spend just a few minutes of our time asking questions about acute stroke and acute MI. And are there any specific questions from the audience? I thought it was fascinating about the AI as a way to drive down the time it takes to get a person to the operating room. When I was involved with a rupture program for aneurysm disease at Erlanger Hospital, we basically met the person in the ER and took them to the operating room immediately, and within the hour we had their aneurysm repaired with a stent graft. And when the stents came in, I think we're going to have one of the docs, Harris, talk about that later, but the first 12 ruptures in town survived. And most of the time, half the time, more than half the time, they pass from the operation. And so it's getting that person to that operating room that's critical. Getting them to the cath lab, we know is critical. Making that diagnosis that they have a MCA territory, lesion is the time. So one question I have for you guys is, are you waiting for the radiologist to call you and say, oh yeah, I'm confirming the fact that there's an MCA lesion, or is AI now in charge of our lives?
I wouldn't say AI is in charge. It's kind of it adds on it. Like most of the comprehensive stroke center, I think, as we have expert in cardiology, kind of expert in neurology, kind of response to all the stroke codes. So we do not wait for radiology. We give our thrombolytic treatment based on our own read. We give kind of going for the thrombectomy. But it helps, I think, because everywhere it's a challenge is the resources, right? That how many radiologists are there who are also need some expertise to read this detailed neuroimaging. Now that AI within 5 minutes sends that message to everybody. So at least that still need a second eye as a human eye that this is a real, because it's not like 100% gonna be the blockage. So you're gonna need a human eye to look at that, whether this could be a chronic occlusion or this could be just a false positive study. But at least you get that notification within 3 to 4 minutes. That changed the game, that at least that activate the team that to look at that. So it's not replacing the human, but definitely with this, all the centers that the radiologists are not have enough resources, that AI has made a big impact.
It sounds like it's forcing our focus. I think that's what it does. I had one experience with a radiology call. It was actually from the ER, a tertiary hospital. Hey, AI says that the patient has an acute dissection of the SMA. I said, well, send it. And so we repeated the CAT scan at the hospital, Park Ridge Hospital, and they had an acute dissection of the SMA, not seen by the radiologist. And we took her to the operating room and fixed her. And so it definitely focuses the expertise. Matt, your comment on AI?
Yeah, so it's amazing we haven't yet. You always get the EKG reads, and the computer will say, "Oh, this is whatever," and yet they're still really relatively rudimentary on the EKG side of it. So what's been interesting is that we've really put forth an effort to train paramedics to read EKGs and be able to interpret and diagnose and make that call to the cath lab. So AI in that space, in the acute MI setting, it doesn't really exist yet, which I find fascinating. And sort of a funny study that was done was they were looking at who reads EKGs appropriately and who doesn't. And the only group of people who read EKGs more inaccurately than a paramedic were ER docs. So nothing against the ER docs. I thought it was a funny and actually pretty poorly done study. But aside from that, it just says that we can empower our paramedics to make those EKG diagnoses and make that call from the field and activate the cath lab. But we just had a case at Park Ridge the other day, very large pulmonary embolism, and I called the radiologist to say, hey, we've got a PE. Oh, really? And then he goes in and he looks, oh yeah, I see that one in my queue. I was just gonna read that in the next little bit. And so, what we've learned is that one of the things that we can make a significant improvement in patient outcomes is the time in which we initiate anticoagulation, the time in which we get heparin going. And if we can get that going sooner, that patient's going to do better. Well, if I'm calling the ER doc as the patient is wheeling off of the table, getting back into their room, and the ER doc goes, oh my gracious, thank you for the notification, then they can start that heparin going right then and there. We can start to make plans after that. So it really is, I think, an additive thing. But the problem, and I don't know if you guys see this on the neurology side, the problem that we're having is the false positive rate is still very, very high. So I'll get 10 notifications, oh yeah, nothing, and oh, finally there's one that's positive. So I have to sift through a lot of noise to get there. So I think AI is making an impact, but I don't think it's there just yet.
Yeah, no, that's awesome. Listen, gentlemen, thank you very much for coming. We wanted to have just a little section on acute. Acute disease happens out there where you all live. It doesn't necessarily happen in hospitals. And so what to look for, what to think about, how to act when that event happens is really critical for that patient's outcome. So please, let's take we have a 1.5 minutes for break. That is just enough time to get a cup of water and come on back in. But we're going to take about 10 minutes, 5-10 minutes, and then we're going to get kicked off with Dr. Harris here. Thanks, guys.